Hello, ladies and gentlemen. Our new program about Efruzhu Oncotherapy, Dosage, Theoryem, and Lawsadvocates, or another same name, Efruzhu Antineoplastic Therapy, Dosage, Regimens, Theoryem, Lawsadvocates, supportive information, short information will be continued. Randomized control colorectal neoplasia prevention trials and different possible application suggestions. Aspirin 325 milligram quote placebo, just like alpha tocopherol 50 milligram every day, beta carotene 20 milligram both every day. Dietary modification targeting reduction in dietary fat and increases in fruits, vegetables, and grains. Calcium carbonate 500 milligram, elemental plus vitamin D3 200 international unit bit. Conjugated hormone example, but not used. Ascorbic acid 120 milligram plus vitamin E 30 milligram, beta carotene 6 milligram, selenium 100 microgram, zinc 20 milligram every day. Selenium 200 microgram every day, beta carotene 25 milligram every day, vitamin C 1 gram, vitamin E 400 milligram every day. Vitamin A 30,000 international unit plus vitamin C 1 gram, vitamin E 70 milligram every day. Low dietary fat 25% of calories. Wheat bran 25 gram every day, beta carotene 20 milligram every day. Combinations: wheat bran fiber 13.5 gram every day, 2 gram every day. Intensive low fat, high fiber, high fruits and vegetables diet. Calcium gluconate carbonate 2 gram every day. calcium carbonate 3 gram every day. Lizin acetyl salicylate 160 or 300 milligram every day. Aspirin 81 milligram every day. 325 milligram every day. Aspirin 325 milligram every day. Celecoxib 200 milligram bit 400 milligram bit. Celecoxib 400 milligram every day, nearly 3 years, 36 months. Rofecoxib 25 milligram every day. Sulindac 300 milligram every day, 4 months. Sulindac 150 milligram bit, nearly 9 months. Sulindac placebo, nearly 6 months. Celecoxib 100 milligram bit, 400 milligram bit, nearly 6 months. Sulindac 75 or 150 milligram bit, nearly 4 years, 48 months. Histone deacetylase inhibitor, very important drug medicine actor, one of them. Suberoyl anilit hydroxamic acid, SAHA, SAHA, SAHA. Suberoyl anilit hydroxamic acid, a small molecule inhibitor of histone deacetylase. In patients with metastatic renal cell carcinoma, SAHA is potent inhibitor of histone deacetylase and can be administered orally with good bioavailability. Hypomethylating agents. Hypomethylating agents. 2 hypomethylating drugs have been approved approved by the Food and Drug Administration for the treatment of all myelodysplastic syndrome subtypes. Both purportedly work through a similar mechanism of action, protection cytosine residue on tumor suppressor gene from being methylated and thus inactivated. The first agent, 5-azacitidine, trade name Vidaza, 5-azacitidine, Vidaza, was studied in a phase 3 trial in which patients were randomized to receive either the drug or supportive care. Patients assigned to the supportive care group could cross over the treatment group if their disease worsened. Patients in the treatment group received 75 milligram meter square, 75 milligram meter square daily for 7 days over 28 days. For 7 days over 28-day cycle. 99 patients were randomly assigned to the treatment group and 92 to the supportive care group. Of the later 49 eventually crossed over to receive active therapy when data were analyzed using SALGB, CALGB response criteria, which differ from IWG criteria, most notably in the requirement for maintenance of response for 4 rather than 8 weeks. CRs occurred in 7% of patients, partial responses in 16% and hematologic improvement in 37% for an overall response rate of 60%. In subsequent analysis of these and other CLGB data using IWG response criteria, Silverman and associated report lower response rates of 14% combined, SRPR and 30% hematologic improvement, major toxicity as with any active agent for the treatment of myelodysplastic syndrome, included cytopenias. Patient also reported nausea and injection site related complications. Decitabine, trade name Dacogen, decitabine, 5-azacitidine, 2-azadeoxycitidine, hypomethylating agent. Decitabine, Dacogen, also was studied in the phase 3 trial in which 89 patients receiving this drug were compared with 81 managed with supportive care. Patients received decitabine at a dose of 15 milligram meter square. Decitabine at a dose of 15 milligram meter square every 8 hours over 3 days with a cycle repeated every 6 weeks. Every 6 cycle repeated every 6 weeks. Using IWG criteria, CRs occurred in 9%, PRs in 8%, and hematologic improvement in 13%. For an overall response rate of 30%, as with 5-azacitidine, major toxicity were hematology. In the 5-azacitidine registration study, a significant delay in transformation of acute myelogenous leukemia or leukemia or death was seen, but not a significant prolongation of survival among patients in the treatment group. In the decitabine trial, no significant delay in transformation to acute myelogenous leukemia or death was observed, probably as a result of enrollment of different patients in each study with more early myelodysplastic syndrome patients in the decitabine study, and of inadequate number of cycle of decitabine dacogen in patients with IPSS into high-risk disease. However, an improvement in delay to acute myelogenous leukemia transformation was seen. The two drugs are considered by most investigators to the clinically equivalent and alternate dosing schedules, including once daily dosing of decitabine over 5 days, every 28-day cycle have been explored. Azacitidine was recently approved by the FDA, Food and Drug Administration, in the intravenous dosing regimen based on pharmacokinetic study in 14 patients. It is clear that present therapy is inadequate for most patients with myelodysplastic syndrome, and new treatments are urgently needed. This is especially true for older patients who in fact comprise the majority of those with myelodysplastic syndrome who are not candidates for intensive therapy or for allo HSCT. Agents such as valproic acid have demonstrated histone deacetylase inhibition and differentiation induction of blasts in vitro, and also have some single agent clinical activity in myelodysplastic syndrome. Based on preclinical studies, histone deacetylase inhibitors have been combined with hypomethylating agents to synergistically induce differentiation and thereby improve cytopenias. Combination studies of valproic acid or other targeted histone deacetylase inhibitors with 5-azacitidine have shown clinically activity and phase 3 trials in comparison with 5-azacitidine alone are in progress. Novel chemotherapeutic agents include chloretazine. Novel chemotherapeutic agents include chloretazine and the nucleoside analog clofarabine, which appear to have significant activity. Lower class. We don't use these drugs for this point. Yes. Selected regimens for the treatment of newly diagnosed multiple myeloma or others. Prednisone. Prednisone 60 milligram day, oral, days 1-7. Repeated every 6 weeks until plateau. Another version, prednisone 2 milligram kilogram, oral, days 1-4. Repeated every 4-6 until plateau. 4-6 weeks until plateau. Thalidomide 200 milligram, oral, days 1-28. Dexamethasone 40 milligram, oral, days 1-8, 15, 22. Repeated every 4 weeks, 4 cycles. Lenalidomide 25 milligram, oral, days 1-21, every 28 days. Dexamethasone 40 milligram, oral, days 1-8, 15, 22, every 28 days. Repeated every 4 weeks, 4 cycles. Bortezomib 1.3 milligram meter square intravenous, days 1, 4, 8, 11. Dexamethasone 40 milligram, oral, days 1, 4, 9, 12. Reduce dexamethasone to days 1, 4 after first 2 cycles. Prednisone 2 milligram kilogram, oral, days 1, 4. Thalidomide 100, 200 milligram, oral, days 1-28. Repeated every 6 weeks, 12 cycles. Prednisone 60 milligram meter square, oral, days 1-4. Bortezomib 1.3 milligram meter square intravenous, days 1, 4, 8, 11, 22, 25, 29, 32. Repeated every 42 days, 4 cycles. Prednisone 60 milligram meter square oral, days 1-4. Bortezomib 1.3 milligram meter square intravenous, days 1, 8, 15, 22. Repeated every 35 days, 5 cycles. Prednisone 2 milligram kilogram oral, days 1-4. Lenalidomide 10 milligram oral, days 1-28. Repeated every 4-6 weeks, 9 cycles. Bortezomib 1.3 milligram meter square intravenous, days 1, 4, 8, 11. Thalidomide 100, 200 milligram oral, days 1-21. Dexamethasone 20 milligram meter square oral, days 1-4, 9-12, 17-20. Reduce dexamethasone to days 1-4. After first 2 cycles, repeated every 4 weeks, 4 cycles. Lenalidomide dexamethasone. Lenalidomide dexamethasone. Lenalidomide double C 5013 belongs to a class thalidomide analogs that are termed immunomodulatory drugs. Lenalidomide appears to be safer and more effective than thalidomide in preclinical and clinical studies. Richardson and colleagues reported activity in a multi-center randomized phase 2 trial that enrolled 102 patients with relapse or refractory myeloma. The overall response rate with single agent lenalidomide was 17%. 17%. Two large phase 3 trials have since shown significantly superior TTP with lenalidomide plus dexamethasone compared to placebo plus dexamethasone in relapsed myeloma. And continue. Bortezomib regimens. Bortezomib bortezomib, formerly known as PS341, is a novel proteasome inhibitor that has been approved for the treatment of patients with relapsed and refractory multiple myeloma in 202 patients with relapsed or refractory multiple myeloma. Approximately one-third responded to bortezomib therapy with an average response duration of 1 year. In a recent randomized trial, progression-free survival was superior with bortezomib than with dexamethasone alone in the patient with relapse of refractory multiple myeloma. Bortezomib is currently approved by the FDA for the treatment of myeloma in patients who have failed one prior therapy. In newly diagnosed myeloma, bortezomib has shown response rate of approximately 40% of single agent, significantly higher response rate, approximately 70% to 90%, have been observed with bortezomib plus dexamethasone. Bortezomib, thalidomide, dexamethasone, and other bortezomib-based combinations, the CR plus or other chemotherapeutic agents. The main drawback of bortezomib-based regimens in the need for intravenous therapy without adequate data that such therapy is significantly superior to orally administered regimens such as thalidomide, dexamethasone, or Revdex. However, bortezomib-based regimens may be of value in patients with renal failure and patients with high-risk myeloma and is not associated with high-rate thrombosis. Glucocorticoids and other agents. High dose plus dexamethasone or intravenous methylprednisolone is a reasonable option, particularly if the patient has had an initial response to steroids and was off high-dose steroids when the relapse occurred. Thalidomide and thalidomide-based regimens. The finding of increased angiogenesis in myeloma and the anti-angiogenic properties of thalidomide led to the first clinical trial with the agent at the university level. This trial demonstrated the response rate of 25% in heavily pretreated patients with relapse and refractory disease. Since then, several studies have demonstrated that thalidomide produced response rate in about 25% to 35% of patients with relapse and refractory multiple myeloma, The median duration of response is approximately 1 year. Thalidomide is usually given in a dosage of 100 to 200 milligram daily. After a response has been achieved, the dose should be adjusted to the lowest dose that can achieve and maintain a response in order to minimize long-term toxicity. Bortezomib and bortezomib-based regimen. Bortezomib, formerly known as PS341, is novel proteasome inhibitor that has been approved for the treatment of patients with relapse and refractory multiple myeloma. In the first phase 2 trial conducted in 202 patients with relapse or refractory multiple myeloma, approximately 1/3 of patients responded to bortezomib therapy with an average response duration of 1 year. These results were confirmed in a randomized phase 2 trial in patients who failed to respond or who relapse after frontline therapy for myeloma. Although initial trials allow maximum of only 8 cycles of bortezomib, additional data indicate that it is safe to give at least an additional 5 or 6 cycles of therapy without under toxicity. In a recent randomized trial, PFS was superior with bortezomib compared to dexamethasone alone in the patient with relapse or refractory multiple myeloma. The starting dose of bortezomib is 1.3 milligram meter square, given twice weekly on days 1, 4, 8 and 11 every 21 days. The dosage might need to be decreased to 1.0 milligram meter square or 0.7 milligram meter square. On the basis of toxicity, bortezomib with or without dexamethasone is an active regimen for the treatment of aggressive relapse. Bortezomib has also been combined with intravenous liposomal some chemotherapeutic agent with a high response rate. Recently presented randomized trial, this combination yielded superior some chemotherapeutics. Lenalidomide double C 5013 belong to class of thalidomide analogs termed immunomodulatory drugs. At first showed promising activity in multiple myeloma in 2 phase 1 trials. Richardson and colleagues have reported the preliminary results of multi-center randomized phase II trial with oral CC 5013 in relapse refractory myeloma of 83 evaluable patients. 24 patients responded with at least 50% or greater reduction in M protein levels. Two large phase pre-trials have recently shown significantly superior double TP with lenalidomide plus dexamethasone compared to placebo plus dexamethasone in relapse myeloma. In these trials, grade 3 to 4 neutropenia was more frequently seen. With the combination of lenalidomide plus dexamethasone, the frequency of grade 3 to 4 infections were similar in both arms. Typical dosing of lenalidomide for myeloma is 25 to 30 milligram per day on days 1 to 21 over 28-day cycle with dose adjustment based on toxicity. Orally on days 1 through 4 with high dose dexamethasone 40 milligram day orally cycles are repeated every 28 days for no longer than months. Yes, combination chemotherapy regimens for Hodgkin lymphoma or others, but we have expression about corticosteroid, prednisone, dose 40 milligram meter square, road perose, 114 days, 28 days cycle length. Prednisone 40 milligram, perose 7 days, 21 days cycle length. Prednisone with other chemotherapeutic, but just only corticosteroid. Now, prednisone 40 milligram meter square, perose road, days 7, 21 days cycle length. Prednisone 40 milligram meter square per oz every other day, taper weeks 10, 12. Prednisone 40 milligram meter square per oz road, days 7, 14 days cycle length with other chemotherapeutic agents. Vitamin A analogs. Vitamin A analogs. Retinoids. Retinoids are derivatives of vitamin A that have been reported to be effective in CTCL. Isotretinoin, acutane trade name. Isotretinoin, acutane trade name, and acitretin, soriatane, and acitretin, soriatane have moderate activity of 25 patients with disease stages at T2 or higher. 44% had a response to isotretinoin, 13 gis retinoic acid, with a median duration of 8 months. As single agent retinoids have limited clinical use. Toxic effects include dry mucous membranes, skin fragility, arthralgias, myalgias, headache, fatigue, and increased triglyceride level. The result of multiple studies suggest a CR rate of 19% and an OR rate of 58%. Bexarotene. Bexarotene at a dose of 300 milligram meter square. Bexarotene at a dose of 300 milligram meter square is a retinoid approved by the FDA, Food and Drug Administration, for the treatment of refractory or relapsed CTCL that selectively activates retinoids receptors. In 94 patients, the OR rate was 49% with a CR rate of 4% and the median duration of response of 10 months. Toxic effects include hyperlipidemia, hypothyroidism, and cytopenias in patients with disease staged as IB or higher. Oral bexarotene may be considered a first-line treatment alone or in combination with PUVA, PUVA, combining PUVA and bexarotene allows for the decreased dose of both does not increase the response rates. Histone deacetylase inhibitor, Vorinostat, Zolinza, trade name, trademark. Vorinostat, histone deacetylase inhibitor. Vorinostat Zolinza is a histone deacetylase inhibitor that results in histone acetylation and activation of gene expression, and is Food and Drug Administration approved. The recommended dose is 400 milligram per day. 400 milligram per day orally. with treatment continuing until disease progression in a phase 2 trial in 33 patients who previously had received a median of 5 prior therapies. 8 patients achieved a PR, 7 of whom had Sézary syndrome. The median time to response was 11.9 weeks. 14 of 31 evaluable patients experienced relief of pruritus. Of 74 patients enrolled in a phase 2B trial. The OR rate was 29.7% in all patients and similar in those with disease staged as 2B or higher. The median time to progression was 4.9 months in all patients and up to 9.8 months in responders with stage 2B or higher disease. Common toxic effects include diarrhea, fatigue, nausea, dysgeusia, and anorexia. Less common toxicity includes thrombocytopenia, pulmonary embolism, and elevations in creatinine level. Prolongation of the prothrombin time is patient receiving concomitant coumarin derivative anticoagulant molecule. That's all this program, and inshallah I hope will be prepared other program, and step by step we will be go absolute total cancer result, treatment, therapy at the end, not far, real solution, not attribution. Thank you very much. Thank you so much. You are patient. I hope you will be join us next program. See you soon. Thanks a lot.